So, hello everybody, welcome to the fourth day of Vincentian Values Week 2023. We've seen some very thought-provoking and inspiring speakers this week, and today is certainly going to be no different. We've got the Marillac Neurological Care Centre here with us to share how they retain choice in care for people with brain injuries and complex needs. So joining us today is Paul, CEO of the Marillac, and neurological speech and language therapist Tess, and activities coordinator Kathy. So I will hand over to Paul first.
Thanks, Fiona. Okay, so today's the turn of MNCC. Firstly, I need to say a massive thank you to Mianna for putting us after St. Joseph's a mating board of advisors, which I think you'll appreciate was an amazing presentation yesterday, but I think from our side, it's going to be really difficult to follow. So thanks for that. So today, Marillac will talk about retaining choice. Everyone knows about the high quality patient care that MNCC provides. At least I hope you do, because we've been doing it for 102 years now. But today will be ever so slightly different. We thought that you should hear from two people that you wouldn't normally get to see, but without them, MNCC would not be the place that it is. So Tess and Kathy, they will introduce themselves in a little bit. We'll today talk to you about the intricacies of choice with people with brain injuries and complex needs, and some of the steps we take to facilitate this. So we hope that by the end of the presentation, you'll leave with a new level of acquired knowledge about the inner workings of MNCC and appreciate the hard work that goes into everything that we do here. So that's me done. Everybody will be pleased to hear, and I will be passing you over to two people with far more skills and knowledge, and they're much more interesting than I am. So over to Tess and Kathy.
Okay, give us 1 second. We're gonna share that one. Go. Okay, so our theme obviously for today is retaining choice in care for people with brain injuries and complex needs. And like we mentioned, we're dialing in from the Marillac Neurological Care Centre. So our themes for today, so what we're going to cover, so we're going to do introductions, we're kind of meet, so Kathy and I learn a little bit about the Marillac. We're going to cover mental capacity in healthcare, consent, and how we empower patients to make choices. We're going to focus specifically on speech and language therapy and how we ensure choice through communication and dysphagia management. And then we're going to cover Kathy and activities and lifestyle, what we do here, how we make a difference through offering choices. We've got some pictures of the team in action, and then we'll kind of close with some reflections and questions. Yeah. So I'm going to minimize this because I can't see. There we go. So a little bit about us. So obviously my name is Tess. I'm a specialist neuro, speech and language therapist with experience in both NHS and the private sector. I worked at the Royal London over COVID, across the stroke and COVID wards. I'm trained in dysphagia management, which is swallowing impairments. I work with 2 caseloads, one for communication impaired patients and the other for dysphagic patients. I'm currently working through my tracheostomy competencies. I support students through neuro placements, and over the last 6 months have taken on an interim neurotherapy role overseeing physio, occupational therapy, speech and language therapy, and music therapy here at the Marillac. And I love all things medical, neuro, brain surgery, stroke, swallowing. I'm that person who will quite happily watch brain surgery videos in my spare time. And I'll hand over to Kathy.
Oh, can you read that?
Yeah. There you go.
I currently work as the activities and lifestyle lead, as well as a volunteer coordinator. I've worked at the Marillac for 18 years. The first 3 years was as a health assistant, and then I was asked if I would like to have a try doing activities, and that's where I've been ever since. This year we facilitated work experience placements for 8 young people, and we do that every summer. During the COVID pandemic, I took on responsibility for the COVID testing. The whole team did. I helped out as a healthcare assistant again, and supported other roles like housekeeping, reception, etc. And like Tess, I love working with all the complex conditions and supporting people non-clinically to improve and take part in our sessions.
So a little bit about the Marillac for those of you who either haven't visited us or don't know much about us. We're based in Essex. We are a 52-bed neuro rehab facility. We treat a very varied caseload, strokes, acquired brain injuries, hypoxic brain injuries, traumatic brain injuries, progressive diseases, so motor neuron, Parkinson's, brain tumours, MS. We've had sort of a really exciting influx of spinal cord injuries at the moment. And so typically anything that affects the central nervous system, we will take in, sort of support, treat, help to essentially optimize before people go back home. And so this is a little bit about our patient contact teams. So we work best all together to ensure best outcomes and quality of life for all our residents. So we're basically formed of the neurotherapy team, which includes occupational therapy, physiotherapy, speech and language therapy, and music therapy, and we work across all 3 wards units. We have the nursing teams, which there's one obviously on each ward, and then Kathy and activities.
Yeah, we work across all 3 units.
So that you sometimes find we cross paths on the units, but we might do activities sort of off the units in a more kind of relaxed environment in the hall or in the lounge. So these are all our patient contact teams. So the neurotherapy team we'll start with. So like we mentioned, we're made up of occupational therapy, physiotherapy, speech therapy, and music therapy. But for the sake of the presentation, obviously given my background, we're going to make specific reference to speech and language therapy and how we retain choice. So mental capacity is probably one of the most important aspects to patient choice, patient care. So it basically seeks to empower patients who may potentially lack the capacity to make decisions surrounding their own care and treatment. It can cover everyday decisions, so from something sort of mundane, everyday, like you and I wouldn't think much of, what to wear, what to have for dinner, where you want to sit in the canteen, to more serious decisions such as escalated treatment, end of life care, palliative care, if that was what pathway we were looking towards. Examples of patients who may lack mental capacity may include those with dementia, brain injuries, so a lot of our caseload, including strokes and traumatic brain injuries, severe learning disabilities, and some mental health conditions. So a patient may lack capacity to make complex decisions, but still may be able to make simpler everyday decisions. So like we mentioned, they may be able to understand and make decisions around what they want to eat for dinner, or whether they want to go to bed at a certain time, or whether they want to watch something on the TV, but they may struggle to make decisions around finance and decisions around their escalated care and treatment. Essentially, as healthcare providers, the mental capacity assessment dictates that patients are assumed to have capacity until proven otherwise. So it's a formal assessment, and until that assessment outcome determines whether somebody is unable to make such complex decisions, we treat them as being able to. Wherever possible, help patients to make their own decisions. So sometimes even aside from the assessment saying somebody might not have capacity, we will help them to make choices on a very low level to ensure that their voices are still heard and they still have a choice in their sort of environment, in themselves. Patients are not to be treated as lacking capacity because their decision is deemed unwise or unpopular. I think that's one we sort of face day to day. And if decisions must be made for somebody lacking mental capacity, it must be in their best interest. So we sometimes have patients who are in a vegetative state. They might be in a prolonged disorder of consciousness. They might be on sort of an end of life pathway where they're now unable to communicate in any respect. And in that, we would work with families, would work with staff to make decisions on their behalf that would basically be as close to, if not the same decision they would make, would they have been able to communicate them choices in the first place. Treatment and care provided to somebody who does lack basic capacity should be the least restrictive of their human rights and freedom. So we shouldn't be doing any less of a service to these people because they can't tell us what they want or don't want. So consent at the Marillac. Every patient, if able to, is asked for permission before they receive any type of medical intervention, assessment, or examination. Consent is taken before every single neurotherapy session. And I guess it's the same for you guys. You know, we never just bring people from their rooms down to treatment areas or activities. Even if we've seen them at 12 o'clock and their next activity is at 12:30, we'll always kind of go back in, you know, you're ready to come back out for the next, you know. And so it's the same thing before any information sharing and before each intervention. If this isn't the case, patients can be put at serious risk if not listened to. And once provided with appropriate information, patients are empowered to make informed choices about their care. And despite their decision, we respect everybody's right to accept or decline care or intervention. And by fully empowering our patients with the choices, we ensure that they are fully involved and in control of their decisions surrounding their care. We often say patients aren't here because they want to be here. They're here because they can't take care of themselves and the families can't take care of them, and they need to be here for whatever reason. So the least we can do is make them feel as in control of their situation that they're already not very in control of anyway. So it's quite something we take quite seriously here. So how do we make sure our patients feel like they've got a choice? Do they have all the relevant information they need? Have they been given information or on any of the alternative choices? Could information be explained or presented in a way that's easier for them to understand? This is where I often come into these assessments, by using simpler language or visual aids. Have different methods of communication been explored, such as non-verbal? We're going to come on to this in a second. Could anyone else help with communication, such as family members or carers? A lot of the times when it's unfamiliar faces, patients feel very, very overwhelmed and quite intimidated. Whereas if we have a family member present, often that level of communication makes it a bit easier for them to access what we're asking them. And is there any particular times of the day when the level of understanding is more optimized? And are there any particular locations where they might feel at ease? Sometimes if we catch people at the times of the day where they're not quite alert or quite sort of as aware of their environment, could the decision be delayed until they feel they might be able to make a better or safer decision for themselves? So how do we specifically ensure choice? So with speech and language therapy, we have lots of patients who are unable to verbally communicate their wants, needs, likes, and dislikes. Many patients rely on eye contact alone, and it can be very easy to miss small cues or attempts to make a choice. Many patients present with speech output difficulties, but have preserved language skills. This means they know what they would like to say, but they're unable to verbalize. This could be due to motor speech disorders or conditions such as locked-in syndromes, which are quite common with certain strokes we see. And for these patients, we have access to high-tech and low-tech augmentative alternative communication aids. So AAC aids is what we call them. So communication aids basically allow us to provide personalized, customized communication aids to patients who would otherwise be unable to communicate their needs. They're empowered and encouraged to extend on what would otherwise be limited and restricted expressive output and decision-making. And so, for example, we create personalized low-tech, which is the little hand you can see moving, which is a paper-based form low-tech aid. And it's used basically day to day when people are moving around the centre. We might see some of our residents with the paper laminated and they can form communication off that. Or sometimes we use what I often give the example of, like Stephen Hawking's device, and people tend to understand what we mean. Is basically a computer tech version of the low-tech paper-based option. Such as grid players, iPads, or grid pads. And this is basically quicker, gives you a wider range of vocabulary. Essentially, this allows our patients to build on their yes and no choices, allowing us to form a more person-centered care plan. So we can get the yes and no's from our residents, but it's the whys we struggle to get if people are unable to communicate. And the reasons for their choices allow us to deliver more tailored interventions, either by reducing or increasing things of dislike or interest. So, for example, this might be one of the tailored communication approaches we use for people depending on their ability to communicate. So I'll let you guys have a read of the table, and you can kind of see. So the open-ended questions would be more for verbal patients who haven't got many restrictions in their and limitations in their communication. It's more open-ended. Then for somebody who might struggle with that, we might give them a controlled choice. So with the reduced ability to extend, you give them two choices, so they can choose from the two choices. At times, we might provide them with sort of visual support. So do you want this one or this one? And for those who can only output yes and no questions, you might close the choices off altogether and give them one choice of one thing and kind of move along the options. And again, this takes into consideration those who are lacking capacity, but can make quite simple decisions day to day. So we'd work through these kind of scaled questions to best meet the needs of our residents. And so another part of speech and language therapy is supporting people who struggle to swallow after brain injuries. And so this is known as dysphagia. And as a speech and language therapist, much of each management plan includes implementing prescription-like recommendations, meaning many patients follow modified consistency diets. This is essentially seeks to prevent somebody from choking, which obviously can be fatal, or developing chest infection, which we call aspiration pneumonia. And this is delivered, you can see from the picture on the side, the IDSI system, which is the International Dysphagia Diet Standardization Initiative. So it's basically a scale of food and drink consistencies that we would work through for somebody with swallowing impairment. So I'll let you have a look at that. And so here at the Marillac, we work hard to ensure that even those with consistency restricted diets can access choices to ensure a better quality of life. So our catering team works quite closely with the department to produce menus covering all modified consistency diets. So this allows patients who follow each diet level to make a choice despite the restriction of a modified consistency meal. So if you look at the top left corner of both the images, you can see it says 6 and 4. So any of the foods in these menus will fall under pureed. So for example, Bailey's egg custard tarts, or is that what it was? And we basically look to puree them so they taste exactly the same, but obviously the patient's unable to have it in their original form. Same with the soft and bite-sized menu. Somebody might still be able to have chicken nuggets, but we're going to chop them up so they've still got the choice of things they probably would have liked before this swallowing impairment, but we're ensuring that they can have it through whatever means is safe for them. And so at times we have patients who, despite understanding the risk of not following modified consistency recommendations, will make the decision to feed at risk. And for example, I might prescribe a level 4 puree diet, but the patient has the right to decline this and insist on eating a level 7, which is a regular diet. So if we go back to this one, so if I'm prescribing a level 4 puree, they might want a regular, which you can see is quite way up the scale. And although not clinically advised due to the risk of chest infections and choking, as clinicians, we continue practicing free of judgment and we respect the choice made. After all, we always say, until you've been in our patient's shoes, it's really, really, it's impossible to ever understand how they fully feel. So we ensure that the guidelines are shared to now support the safest way of eating and drinking if that patient is going against medical advice, technically is what we'd say. So I'm going to give you an example, and we'll remember this lady quite fondly. So we had a lady here, I think she discharged from us last year. She was in her 20s. She'd had a stroke and as a result was completely dependent on others for all aspects of her care, communication and swallow feeding. Her brain injury resulted in a partial glossectomy, which is a tongue resection. So she had part of her tongue removed. And this massively, obviously, as you can imagine, impacted on her swallow safety. And she was recommended to be nil by mouth with a PEG tube, which is a stomach tube feed. She declined, and we completed a mental capacity assessment to make sure that she could understand the decision she was making. And using the high-tech device she was provided with, she was able to give us more information. And I'll never forget what she said. And she said, "Eating is the only thing I have left to enjoy." And so we said, okay, fine. So she agreed to risk feed. We okayed it with the care staff, and the most we could offer her was a puree diet because without the tongue, she was struggling to move around the textured consistencies. Staff would constantly worry about the safety, but would feed her meals as per the guidelines. And I remember her being happiest during meal times. She loved the social aspect. She loved just being around food and maintaining that part of her old life, which would have otherwise been basically inaccessible for her with the recommendations her clinicians had put forward. And so in summary, this is just, I thought it was a really nice quote. The patient's autonomy always should be respected, even if it's absolutely contrary to the medical advice from clinicians and physicians. And as hard as it is sometimes for us to accept patient choice, patient autonomy is essentially quality of life is at the heart of sort of everything we do.
Yeah.
And I think with that, I'm going to hand over to Kathy.
Oh my goodness, you're a hard act to follow.
Go for it. Yeah, there you go. There's stuff.
Okay. So activities and lifestyle team, how we retain choice. A bit about us and what we do. We deliver 800 sessions of non-clinical care. This includes cookery, sport, bingo, quizzes and painting. We provide non-clinical assistance in the form of supporting residents, family members, etc. We provide a variety of groups covering 3 sessions a day. We're made up of 5 staff. We've got approximately 30 volunteers who support our groups throughout the day, evenings and weekends, and who we would be lost without. They're very valuable, and a lot of our groups wouldn't continue without their help. We've worked in this team for a combined 39 number of years. This is a lot. We work with 52 residents throughout the week. We work for 6 days a week. The 6th day being a new thing. We've just started doing a Saturday and having a group with young volunteers that want to get involved. And we're a gateway to promoting achievement and avoiding isolation. Choice through preparation, gosh. So we ensure that there are copies of our weekly schedule visible in all residents' rooms. Every day we go around the whole house and we go and visit each resident to let them know what we're doing, so it gives them time to think which activity they'd like to attend. We ask the residents if they've got any ideas for art and craft or recipes in cookery. We've got a list there of all the different things we do: cooking, arts and crafts, gardening, pottery, music and entertainment, animals. We've done a variety of things over the years. Cookery, we have a lot of the volunteers come and help us with cookery, which is vital. Arts and crafts, some of the residents have got past hobbies that they would like to continue, and they're able to in that. We have outside entertainers coming in once a month. We have a singer, or we've had dancing, we've had animals, we've had someone coming in with pottery so they can paint, or numerous things go on. Cross-stitching at the bottom there. Some residents that are more able to use their hands can get involved with doing things like sewing. How do we offer choice in our sessions? Within a session, patients are presented with a selection of options, i.e. board games or movies. With an art session, we consider preferences and levels of sensitivity following brain injuries when offering a selection of mediums, i.e. finger painting, pencils, glue, paintbrushes and felt pens. We've got a good selection of resources. And once again, we get feedback from the families so we can find out what their family member previously did before they came to the Marillac. We speak to them about what they'd like to try as well. With the allocating, instead we do not tend to allocate seating. We like them to have their own choice to come in, because they like to socialise. New friendships are created at our groups. People from different units come together, they're people that would not normally have met in life, and they're thrown together, and some get on, some do not. We have some interesting sessions sometimes. But overall, we let them make their own choices, make their own friends in all that we do. Oh, wrong thing. We have a patient-centred approach. For many, self-care and pampering was a keen interest prior to their impairments. We strive to ensure that they can feel taken care of through regular beauty sessions and relaxation groups. For example, we provide choices of the following: manicures and nail painting, haircuts. Our hairdresser is actually one of our team members, which is really quite handy.
Really good.
Because she knows everybody, they know her, so they feel really comfortable when she comes in and says, right, it's time to cut your hair. We do hand massages, face masks. We facilitate external eyebrow shaping and appointments. We regularly take residents to local coffee shops for lunch as a means of ensuring they have regular access to the community. So we've got a cafe not far from us that has wheelchair access, and we're able to take residents there, and we let them make their own choices. They go up and order their own food. We stand back. And they get talking to people. It's amazing when you go out, people will just talk to them, and it's a really great interaction for them. We go to the local news agents and they can go around, choose their own snacks and things like that. Supporting communication. Many of our residents have communication aids, for example, the ABC chart and grid players like Tess mentioned earlier. During quiz sessions, residents bring their paper-based communication aid systems, which allows them to participate without limitations. These are great when we're doing a quiz and you've got some residents that can answer quickly and others that cannot. So we have to make them take turns. So we have to say, well, you're not to answer because we're going to wait for someone else to say something. So they will then point to a letter and show what they want, what the answer they think it is. One resident in particular emails via his high-tech communication aid. He often expresses any issues he's facing or makes requests during this device. He also does an aphasia session, doesn't he?
Yeah, his music group.
Yeah, he's got a music group that he attends. That's there's about 25 people from the community. He doesn't know any of them, but they do exactly what we're doing here, a Zoom call, and they all choose 2 songs each that they would like to listen to, and then they all judge each other and mark from 1 to 10 what they think. And most of his are a 0. He's very hard to please.
Yeah,
so funny.
He's been doing that for years as well, hasn't he?
Yeah,
quite a long time. Yeah.
Yeah. By providing residents with these choices through different means of communication, we reduce their frustrations and feelings of loneliness or isolation. Sorry, I'm reading this wrong. We see firsthand how effective communication improves patient experience, which it does. Oh, here's some photographs of some of our sessions. So you've got some volunteers and staff members on the cookery session. They're making pizza. Sarah is there busy making her, but they love doing this. They love choosing their toppings, and they get a little bit of input in what recipes we make. We don't do anything too fantastic. I had some requests for some Indian food recently. We were like, I don't think so. We don't know how to do that. So we stick to basics.
Things are quite straightforward.
Yeah. Here's a couple of our volunteers. We have volunteers of all age. Well, they have to be over 16. But they're great coming in, spending our time. I love it when the youngsters come in, especially.
Yeah.
Group bingo session. We play bingo twice a week because it's so popular.
Oh, it is. We get people turning down therapies to go to bingo.
Here's one of our recent entertainers that came in.
Yeah.
She was great with her accordion, and yeah, he's loving it, isn't he? Sandy planting some herbs with his wife. They've got a purpose-built table. We've got a couple of these at the Marillac where residents can get out and do a little bit of planting in the good weather. We have an interactive table that you can see on the right-hand side, which is so popular.
Oh, it is.
Yeah, all the time with
gatherings, isn't
there? Yeah, lots of people collect around it, and we try and come out and help them because, again, a lot of the residents are unable to actually use it themselves. They need someone else to be their hands, but they can see the words and they can tell you where they are, and then we have to be their hands. A little bit of art and craft here, stone painting.
Was popular as well, wasn't it?
It was, yeah. They enjoy stone painting. John's got them all on the trays. We go and drop them. We put them around the sensory garden, and when the residents go out for walks, they're able to spot them. We always say, "Can you see this?" or let's try and find the red one or whatever. And you said something the other day.
Yeah, we were using it in therapies to get someone to bend down and pick things up.
Yeah,
which is good. Yeah,
to learn to stretch. Okay, so the outcome. Essentially, our residents use sessions to gain confidence, switch off on the clinical side of things and socialise. We welcome family members to support their loved ones during our sessions, which they do. We have lots of family members that come and join us. And it's great. We all chat. We have some lovely conversations. There's laughter. There's fun. They're really good groups. Yeah. We seek to prevent residents feeling socially excluded and encourage them to socialise. The activities we deliver incorporate their hobbies and interests and quality of life. We often help the residents to achieve their clinical goals through subconsciously practicing areas such as hand and eye coordination during craft sessions, or sequencing during cookery, and at times their communication when singing along to music. And I think that might be the end, do you think? Is that the last one? Oh,
What's the last one?
questions.
Let's open everybody back up.
Oh,
Oh, how do we do it?
You have to take that one down. Oh, that's not.
Oh, there we go. Stop there.
Yeah. Kathy, you spoke about 800 sessions. Is that per annum, per week, per month?
per month.
Per month. Wow, that's something, isn't it?
Yeah, yeah,
Wow.
yeah. We have a lot of interest.
Yeah.
Does anyone have any questions at all? That was incredible.
Yeah, you just mentioned music at the end there, and I'd just be interested to know, a friend of mine had a stroke, he was 65 or so, but had a stroke last autumn, and it's left his speech really inhibited, to tell you the truth. And but we took him through to a mass through in Edinburgh last Sunday, and we played a CD, and I noticed he was able to, and it was all hymns, you know, various different hymns that he was familiar with, but I noticed that he was able to articulate, actually verbalize more singing the hymns than he could just talking the words.
Yeah.
And I was wondering, do you find that the case with your patients with regarding music?
I think so.
I think
We've got
so,
a lot of
yeah.
residents that can't speak, but they can sing or they can mouth the words to songs.
Aye.
Definitely.
But if they didn't have the music and you put the words in front of them without the music, they probably would it be the case that they couldn't talk the words, but if you put it to music and it was a song they knew,
Yeah, definitely.
they could
We
sing the
definitely
words,
have that.
but not
Mm.
speak the words without the music. It's
Yeah.
fascinating what music can do, isn't it?
Yeah, yeah, it's
Yeah.
it's a big
Yeah.
one.
But you find that in your experience that that's the case, yeah?
We have, and so we do joint speech and language therapy sessions and music therapy sessions for some of our residents, and we find that it's quite a nice sort of mixture of target and communication, but using a sort of medium that a lot of people find quite motivating as a point of interest through the music. And so, like you're saying, obviously the different parts of the brain control different functions. So where one part of the brain controls the speech, another part controls the memory and the rhythm, which is where I think music tends to be a more comfortable medium to try and communicate through, because you're coming back on memories and things that you knew once before that you otherwise struggle to access without that kind of memory side of things, and the rhythm and the music and things that we already stored once. But we often find, so with Craig, who you saw, let me get it back up, you can put a name to the face. Where is he? This gentleman on the left. He again is somebody who struggles to communicate, but singing
Yes.
is absolutely brilliant, isn't he?
Right.
So yes, exactly as you're saying, we do often see clusters. We do see that through our sessions, don't we?
Yeah, yeah. And there's some residents that aren't keen to come to our activities, but they'll come to the music. Or they don't necessarily even know it's going to be music. So again, it's the way you say your question. Come with me, we've got something to show you. Don't say, do you want to come? Because they'll say no. And then you bring them, and then the music. And we have a lot of tears through music, a lot of emotion.
Yeah.
Yeah.
That wasn't in such situations, that's not an informed choice, but it's in the patient's best interests, if you know what I mean. You know, you were saying earlier on about informing the patient so they can make an informed choice, but you just used a wee bit of informed craftiness to get them along, because you know,
because you get some residents who are quite sort of low in mood when they come to us, just generally, and they don't want to participate in anything. It's very common until they kind of see one thing, and then they slowly kind of creep out.
Yes.
And then you see them sort of increasing in their interaction. So we have ways, don't we?
We do, yeah.
It's good, because certainly in relation, the work you do is absolutely incredible. The intensity and similar to the session yesterday, it's so much centered around the individual. It's wonderful to know these things. You know, it really is. It's wonderful. And I think the work you do is absolutely terrific. You know, but I noticed with my friend Paul, socializing, is a tendency to withdraw to an area where he feels safe. He's home and mentally as well. Do you know? But anyway, there you go. But it's marvelous what you do. It really is absolutely terrific. Terrific to know that that this work goes on. Do you know? Every day, every week, every month, and the volunteers as well.
Yeah,
It's
they're great.
extraordinary, isn't it? The
They've got a
goodness
great band of
that's in people.
volunteers.
Marvelous, absolutely marvelous.
Thanks, Kevin. Does anyone
Could
else?
hello? Could I just ask, are all the residents long-term staying in the Marillac, and when they're discharged, do they have any follow-up care?
So our typical pathways are 12 weeks. So somebody might come to us for 12 weeks of neurological sort of treatment and therapy, and then access Kathy's team for the activities. It depends where people are discharged to. So we work with social workers to place people in the community. So that means they might go home. Sometimes people might need to go to further nursing residential facilities. We've got a gentleman at the moment who we're looking to discharge to a mental health facility. Typically, our care would end when the person is discharged, but we ensure they are followed up by the NHS or community teams closer to where they're going. So we would always refer onwards, and we always leave somebody with a social worker at the end of their time with us to make sure there's that continuity of care even after they've finished their time with us here. Yeah, so we do ensure there are follow-ups with teams that they become familiar with along their sort of journey here with us.
If after the 12 weeks on your pathway, if they still need further care and further improvement in their status, can they stay in the Marillac?
I'll pick that up. The commissioning is quite interesting. So most people who come to us will be commissioned via the health services, by the NHS. And quite often when people leave us, their care transfers over to the local authority. So we're kind of a conduit between the National Health Service and the county councils. So when it comes to funding placements, they'll start off being funded by the NHS and then into the local authority. So if they do 12 weeks of rehab, the chances are once that's been finished and it transfers over to the local authority, if there's longer term care, they will normally go to a placement outside nearer to home. Would it be the Marillac? It could be, but it's very rare that the local authority would commission care here. The health services would, but the local authorities don't, mainly because we've got nursing and therapists here, so the local authority won't commission services from us. I think there is still a lack of appropriate care and move on facilities after the Marillac. And I think when you look at what the Marillac was set up to do all of those years ago, which was to provide services for younger disabled adults, it was back in those days, it was tended to be a home for life where people would come in and spend many years here. And when I first arrived, we had people who had been here for 15, 16 years. And we still have a few left who come in here for 12 or 13 years. And we've had a few people coming in down that pathway. But those are sort of getting less and less now, and they're being transferred over to local authority. And I think there is still a gap out there for services that cater for younger adults once they leave here. So they will possibly be put into inappropriate placements. But we try our hardest to get people ready to go back home rather than to go into other services.
Thank you.
Can I just ask a question? We're here at St. Joseph's Team Leaders meeting, and thank you ladies for a really interesting talk. It was wonderful to hear about all the lovely, amazing work that you do. You spoke a lot about volunteers, and you seem to have a really enthusiastic team and a large team. We just wondered where and how you recruited those volunteers.
Some of the volunteers have been with us for years. they came through, I don't know, I think it might have been through the cathedral. They have a newsletter, and I think adverts went into the local, like into there, and we got people from there. Word of mouth.
Sometimes we have students. So I had a couple of clinical students, and I think they were in touch with their peers on their courses, and then we had a friend come in. Do you remember?
Yes,
She did a bit of work with us on the unit. So
yeah,
I
and
think
we've got Volunteer Essex. We're on their books.
Yeah,
They send
universities.
people. Yeah, people come to us quite often. The youngsters that come to us for work experience come back later on as volunteers, or they know somebody. It's often word of mouth.
Some of them.
I don't really have to advertise for volunteers at all.
Yeah.
They just come.
It's either word of mouth or it's people having a contact with the Marillac. So quite a lot of people will come here, either they retired but they still want to maintain contact with us. It will be people from different religious organisations, Catini and stuff like that. We used to have a very good network, which was the Friends of the Marillac, which was a group of individuals who would come up and they fundraised on our behalf by running car boot sales. They were very, very active, and they were all from the locality. So I think an awful lot of our volunteers came through that network as well. They ceased, I think it was about 3 or 4 years ago. But we still find that people tend to come through to us. Like I say, we're very known in the community, so a lot of it tends to be word of mouth, and then we'll go through that process.
Yeah.
Mark, did you have your hand up? Yeah.
I was going to so I thought the section on feeding at risk was absolutely fascinating in terms of kind of keeping resident choice and autonomy as sacrosanct. I'm just a little curious around how the conversations take place when it's against medical advice, but the patient or the resident is very strong in their choice. How that conversation plays out and how those wishes are respected as best as possible.
Normally, when we start, so we will do a period of assessment, and then the recommendations can become quite clear towards the end of the assessment, and we will start to have those discussions about the options we're thinking of as clinicians with the patients. And usually quite early on we'll get almost like a bit of kickback saying I'm not willing to do that. You know, how do you expect me to live happily if this is what, and we understand that. So as clinicians, it's our responsibility to put those risks forward and explain the dangers of not following medical advice. Having said that, if somebody has mental capacity to understand what it means to go against those medical decisions and the advice we're giving, that's absolutely fine as long as they have mental capacity to understand the decision they're making. And then at that point, I think it's more about getting staff on side, because we get quite anxious carers if somebody's not able to feed themselves. And it's about sort of working through that and understanding that this patient has made that decision for themselves and we're not the ones putting them at risk, kind of thing. And obviously, just because somebody decides to risk feed there and then doesn't mean it's an indefinite decision. They have the right to take that decision away if they start to feel like this is becoming an issue, or if it's actually something they're not too comfortable with. So again, the patient is in control of that decision the whole time, and we will regularly review how they're managing what they're now having. But usually it's a discussion we have quite early on in the feeding sort of pathway, to make sure that the patient is as safe as possible, but there is obviously the added risk of choking or chest infections and whatnot. So if somebody has the ability to understand the decision, usually these conversations are had quite early on. Having said that, if somebody doesn't have mental capacity, they obviously wouldn't have the ability to make that decision. So it's not something that we deal with very often, to be honest. I think we have, say, 2 or 3 risk feeders at the moment. So in 52 residents, it's not very common. But for those who are non-compliant with the recommendations, we have a sort of system in place. They would then sign a form to say we understand what the decision is we're making. This is cascaded through sort of consultants, through their care plan, through families, through their GPs, so everybody's on the same page. So if their chest status was to deteriorate, if they were to have a chest infection, everybody would know where and how it had come about, because the patient has decided to make this decision. So it includes everybody, although we as speech and language therapists will kind of drive the decision forward. Everybody from the MDT, doctors, nurses, healthcare assistants, occupational therapy, if they're involved in feeding, would need to be on board to make sure it's kind of implemented across the whole team. Yeah.
Thank you. Any last questions? Sister Ellen.
Well, first of all, thank you so much. I'm kind of mind blown by all of the detail of what you do, Tess and Kathy, and the way that it's kind of so detailed in its thinking through and so on. Obviously, very skilled and professional work, and delighted that our residents, you know, get that as well as the clinical side of things. I'm not saying that your work isn't clinical, but you know what I mean. It's like it's more on the word that struck me was isolation, and the bringing of people together to do things in the dim and distant past. And I mean the dim and distant, a long time ago, I used to come along at Christmas to do carol singing with residents and families in the hall. And because it was Christmas and because it was carol singing and because families were together, I mean, I recognize your thing about people can sometimes sing when they can't speak. I could see that. And in the past, you know, long before that, again, I did a little bit of music therapy myself. The thing that fascinates me and that I want to ask about is that people got very upset because music evokes memory. You know, we all get upset at Christmas sometimes when we're singing a carol, you know, because it's nostalgic. And what I wonder about, maybe this is straying into psychology, but I used to worry that, you know, on the one hand, memory is a good thing, and music has an enormous ability to evoke memory. But at the same time, for somebody who's remembering a time before, if it's an acquired brain injury especially, you know, how does that relate to the process of healing in memory? So is it a painful thing to evoke memory? Is it good to do that? How do you deal with it? How does it move on into the acceptance of what's happened to them? Sorry.
I think that's a really deep and meaningful one, Ellen. And I think
because really, I've been there and it used to worry me.
I think it's a really, really valid point. I think we've got a lot of people here who, when they arrive, as Tess and Kathy have both said, they're in trauma when they arrive. It's not an experience anybody wants to go through. I think Peter describes this place as the nicest place you never want to have to go to. I think when you look at music, we have a sensory room next door that is very, very well used, and that actually has an awful lot of music activities. It's got simulated bands, and actually what you do find is that residents really look forward to going in there, and especially the ones with a musical background, they enjoy going in there. They enjoy playing the music in some shape or form that they used to in their youth. I think it's always going to be emotive, and I think one of the things that you said, how do the residents deal with their newfound normal? I think the people who find it more difficult are the relatives, their husbands, wives, in some case mothers and fathers, brothers and sisters, sons and daughters find it more difficult. I was talking to one of the residents the other day and saying, you're actually very inspiring, because whatever it is you've been through, you're still smiling. You're still doing things that most of us would say, actually, my life is entirely different to the way that it was meant to be played out. I wasn't meant to be in a wheelchair. I wasn't meant to be sleeping in the Marillac. I was supposed to be out and about with my friends, going to the football, having a few pints, and I'm not. And this person just looked at me and said, but you just get on with it. My life is different, but you get on with it. Whereas if you speak to that person's mother, they would probably break down, because that's not the life they anticipated for their child. So yeah. I think the residents deal with it an awful lot better than the relatives. Mm-hmm. And I think with that in mind, we appointed a psychologist here who works here 1 day a week for both the staff, the relatives, and the patients. And actually the most use that he gets booked for is actually the relatives. So it will be the mothers, the fathers, the husbands and the wives, because bear in mind, we do have quite a few younger adults here. So we're talking younger adults in their 20s and 30s. So the parents who are getting ready to have their life again, who are going to go on holidays, who are going to have the independence because their children had flown the nest, all of a sudden revert back into the caring field again, which is something they never anticipated doing. So they adapt their house to get their son or daughter back. So those guys need a huge amount of support. So although it kind of varied off from the track of music, I think it's the residents themselves actually deal very well with their current situation, but the relatives not so much.
Right, yeah, I can see that. Thanks.
And just quickly to say, our approach is very patient-centered before the patient even comes to us sometimes. So we do something we call pre-assessments. So we might get a referral for our residents and a nurse, so usually if it's Precious and I, and we'll go and kind of assess the resident, whether it be virtually or not. There and then we will often ask, what are the hobbies and interests? What are the things that the patient might not want to take part in or might be triggered by?
Right.
And often it's there and then it's stated actually the patient is quite triggered by the events that have taken place in the last 3 to 6 months or whatever it's been. So we know when we're getting them in, this information is going to be cascaded across the team at the Marillac, so just be wary if their patient is around the topic or whatever it might be, will upset them. And in that case, like Paul said, we do usually have psychology on standby, but we're very aware before the patient is even admitted to us what will likely trigger them and try to avoid them topics until the patient indicates to us that they're ready to talk about it or ready to address it. And usually in time, within about a month or so of them being here and settling, they do start to come out and they will kind of slowly come to terms with it. You know, this is what I used to do before. And then that's kind of our cue to sort of support them along that healing time. So we gather as much information we can about what they like and dislike prior to them even coming to us, which again, I think feeds into the choice. We give them a choice of what they will and will not want to take part in, and ensure that the journey here with us is based around the information we gather sort of prior to the admission.
Right, yeah, thanks very much.
I think, sorry, inevitably, when people are coming in, it's probably the nursing staff who will get the butt of anger, either from relatives or from the patient themselves. And you know, is there a time frame when you see a turnaround, or is it sometimes that there's never a turnaround? Yeah, I mean, I'm one of the trustees in the Marillac, so I kind of have a bit of insight. But it would be handy just to talk about that for a minute or so. I just wonder how the ongoing stress of somebody constantly angry or a family constantly angry is dealt with even at unit level, because I feel it very much for the nurses sometimes. I know it's a multidisciplinary team and you're all in it together, but I suppose the nurses are the ones that are there 24 hours a day. I suppose I'm speaking as a nurse as well, so yeah. So just a comment maybe.
I think thank you for that, Sister Kathleen. I think one of the things that we try and do is make sure that, because people will get angry, but they get angry because they don't know what's happening and they don't know what the future holds. So what we try and do is we describe it as a meet and greet. So within the first week of people being here, we try and assemble a meeting of the professionals involved, the family, the residents, so that everybody knows what the plan is. And that tends to give people the information that they need. And actually at that moment, it kind of does a couple of things. It lets them know what the plan is. It lets them know what the care plan is. It lets them know what we will be doing, how many sessions of therapy we'll be doing. And it actually gives them something to come back to us and say, well, actually, we don't think we're getting what you said we were doing or what we were going to do. But it also allows us to say, but don't set unrealistic expectations, because quite a lot of the time people will come here and get angry because they're not getting what they think that they need. And actually the professionals might have a slightly different view. So it is the forum that we would use to try and make sure people get all the information. And that tends to dissipate any anger. There will always be people, and they are of a minority, who will be angry with the fact that their relative has to be here. And actually, yes, you're right, they will sometimes seek to vent at either the nursing staff, the therapy staff, sometimes the admin staff. But the nurses and the staff are incredibly good at kind of absorbing and then trying to turn that round. Most of the time we're successful.
Can I just add something here? Because we see quite sometimes anger issues in our groups. And I got talking to a family member just last week who said that they'd been out around in our sensory garden. We've got a little smoking area, and one of our residents likes to go out for a cigarette. And he's unable to hold the cigarette himself, so she has to do it. And she said that she was here a couple of months ago, and he was so angry. He was so angry about his situation and what's happened to him. And she said, I can't believe him. I saw him the other day. She said, he's so different. She's so calm. And she said, he's got that Marillac smile, which I thought was brilliant. So, yeah.
And I think with the families, there is often a lot of anger, but it's often a combination of uncertainty, not being aware of sort of what this is going to mean for this person at the center of what we're dealing with, and how to ask those questions. And often what I find as a clinician, from a clinician's perspective, it's often education. So I will often print out diagrams, or I print off the brain, and we'll say, well, this is what's happened, this is what this is going to mean, and this is kind of where we're going to work and we're going to move towards. And I think it's about being really realistic, and often that means we have to be the bad guys. And so with nursing, we couldn't manage without nursing, but obviously therapy is a very different team, and so we would be the ones driving forward that rehab. And a lot of the times we get families coming in and saying, oh, our loved ones are going to walk, our loved ones are going to talk, and they're going to be able to go back to work. Now, looking at this person, you know that that's nigh on going to be impossible, but there are things we could do, you know, alternatively. And I think it's that repeated education, helping them to come to terms with what's happened. And like Paul said earlier, we at times quite naively see these centres as somewhere that would take care of people in their older years. But we've had so many people, young people. I mean, we've just had an 18-year-old admitted to us. And I think that it's hard for us to come to terms with sometimes. And mentally, it can become quite difficult to have to see what people are going through. And so it's the younger people we see quite angry, I think, family members, because it's completely not what they expected to be dealing with. Like Paul said, adapting houses to make it easier for your child to come home in their wheelchair after living a completely normal life up until 2 months ago. So it's about kind of understanding. And I always say, if you talk to any of my team, I always say we are in no position to judge somebody's anger until you've been in that position. And so when they come back and they unfairly attack me, I say it's completely justified. We don't know what they're going through. Just work with them. And obviously if it becomes an issue, we do get family members that get quite aggressive. Obviously we'd escalate it and deal with that accordingly. But often they just need someone to listen to them, don't they? Yeah. Well, we just sometimes and we often say, we had a gentleman who would spend half an hour of his 1 hour allotted therapy time, and he'd come and cry. In the bungalow, the gentleman, and he'd come and cry with us. And that would be we'd make time for him to just come and cry, and that's literally all we needed, because there was the only way he could express how upset he was at what was going on. So it's on a sort of case-by-case basis, but we're quite good at helping people through, aren't we?
Yeah, and I say in a lot of our groups, we have conversations, they share their problems. Yeah. Someone else has got something different going on, and they just discuss what's happened to them. And it's good. It's talking, communicating is good.
Thank you. Well, we're just about at the hour now, so we're going to have to wrap up there, but just a huge thank you to Tess, Kathy and Paul for that incredible presentation. It was so informative and a really in-depth discussion there. So we've all learned a lot, and I'm definitely blown away, and I'm sure you all are by the work that takes place at the Marillac. So thank you so much again. Tomorrow is the final day of Vincentian Values Week, and we're finishing with an event at 10 o'clock again, where we'll reveal some of the key findings from our social care survey that we've undertaken over the summer. So please do join us for the final session. And again, thank you so much for today.